Hi, I'm Dr. Harris at California Hernia Specialists. Quite a few of our patients have asked us about nerve injury and nerve damage after hernia repairs. So I wanted to take a few minutes and address that concern. The most common hernia procedure that we perform that is at higher risk of nerve injury is the inguinal or the groin hernia repair. That's because the nerves that run through the groin tend to run right next to and adjacent to where the hernias form and where the intestines or the fat push out through the muscle. That isn't the case typically with umbilical hernias or even ventral hernias along the midline or the anterior portion of the abdomen. There are no big named nerves that run through the belly button or through the umbilicus where umbilical hernias form, and that's the same for ventral hernias above that. So we typically don't see chronic pain or nerve pain after umbilical or ventral hernias. So what I'm going to discuss is mainly focused on inguinal or groin hernias. In the groin, there are about 3 nerves that we typically see and are typically responsible for chronic nerve pain after inguinal hernia repair. Those 3 nerves are the iliohypogastric nerve, the ilioinguinal nerve, and the genital branch of the genital femoral nerve. So that's 3 big medical terms, but basically there are 3 small nerves that run through the groin, all the way from the back and from the spinal cord. They run through the groin and then down to the skin or different structures that they innervate. Fortunately, none of those nerves are motor nerves, meaning that they don't control motor function, meaning they don't control your leg, they don't control your muscles of your groin or the rectus muscles or any of the male structures in that area. They're only sensory nerves, which is good and obviously bad because if they are injured, it can lead to chronic pain as a sensory complication. During inguinal hernia repairs, we always look for the ilioinguinal nerve, and that nerve is usually fairly easy to find. It's usually running right along what we call the cord structures, which are the arteries, the veins, the vas deferens that all run down to the testicle, and that ilioinguinal nerve usually runs right on top of or just next to those structures. We can usually find that nerve easily, and then in my case, we preserve that nerve and move it out of the way, do our hernia repair, and then lay it back in its normal course. There's also the iliohypogastric nerve, which runs several centimeters above that and typically isn't involved with our hernia repairs. If it's a small to moderate sized hernia, the iliohypogastric nerve is usually running much higher than where we're operating, and we typically don't need to even touch that nerve. The genital branch of the genital femoral nerve is an extremely small branch which runs from inside the abdomen through where the arteries and veins are passing for the testicle and then run down the cord structures. You know, the best way to avoid trauma to this nerve is by minimizing the dissection of the cord, which again are all those structures running down to the testicle. And in our case, we only peel the hernia sac off and we leave as much of the normal fat and connective tissue as we can to avoid injuring and disrupting that nerve. So a couple of important things. There are some surgeons out there that purposefully and actively cut the ilioinguinal nerve during surgery in hopes of helping prevent chronic pain afterwards. Again, it doesn't affect any malfunction, but it does create a little bit of numbness of the upper thigh, a little bit of numbness of the very, very upper scrotum, and a little bit of the skin in that area. Over time, that usually improves, but some surgeons feel that this minimizes any chances of chronic pain afterwards. In our practice, we don't do that. I don't think it's wrong to do that, so some surgeons that do, we certainly wouldn't disagree with them, but in our case, we feel comfortable preserving that nerve, minimizing the trauma, moving it out of the way, repairing the hernia, and then again laying that nerve right back down where it normally runs. The chronic pain that patients typically see after hernia repair, it isn't always a nerve pain. There are some times where just with any surgery there can be chronic pain, whether that be, and I've talked about this in some of our other videos, there can be chronic pain after shoulder surgery or hip surgery or knee surgery or back surgery. and the same can be for inguinal hernia repairs. Again, minimizing the trauma to the nerve, not moving them any more than we have to, not disrupting them any more than we have to, are all ways to help minimize damage and hopefully minimize chronic pain to those nerves. Again, the mesh that we use is an ultra lightweight mesh, so it's a very thin mesh. In years past, some of the thicker, heavier plastic meshes did cause an increase in the inflammatory response in the groin, and were sometimes speculated to cause more inflammation around the nerves and thus worse pain afterwards. Again, we feel very lucky. We don't see a large volume of chronic pain patients after our inguinal hernia repairs. Again, minimizing trauma to those nerves and using a lightweight mesh seem to be certainly very, at least hopefully, beneficial to our patients. And again, just the fact that the groin is more of a mobile area, and after surgery, any scar tissue could possibly cause some discomfort in those nerves. So in any case, those are the three nerves that we see during inguinal hernia repairs. Again, umbilical and ventral and epigastric hernias, incisional hernias typically don't have that chronic nerve problem after surgery because there aren't large nerves in the area. So I hope that helps a little bit in discussing the nerves that we see, a little bit about what myself and other surgeons sometimes do to help minimize nerve pain, and hopefully it won't be a factor for you. So in any case, if there's any additional questions, feel free to give our office a call. We're always here to help. Thanks.